Hello everybody, we are going to continue with our second case in our restrictive lung dysfunction series. It's a 36-year-old Ethiopian woman presents to the hospital with a 6-month history of lethargy and intermittent severe left upper quadrant and epigastric abdominal pain. The first thing I just wanted to quickly hit was this description of the quadrants of the abdomen, because I know we didn't talk about this in pathophys, and so I just wanted to put it on your radar, kind of the anatomy when we're describing the different quadrants. So she has left upper quadrant pain. In the left upper quadrant, we have stomach, spleen, and part of the colon. If you go to the right upper quadrant, that is where we find liver, gallbladder, and large intestine. The lower quadrant, if we go to the left, we have the last part of the colon and ovaries. The right lower quadrant is colon, last part of the small intestines, your appendix, and also obviously ovaries. So just giving you the anatomical background, because that description gives you a good idea kind of where we are in the GI system. She reported a 15-kilogram weight loss, no history of fever or night sweats, complaints of mild dyspnea, and non-productive cough. If you look at through the medical examination that was done, they report moderate cachexia. So that is the loss of kind of lean tissue independent of caloric intake. Her vital signs were unremarkable, and there's no jaundice observed. The respiratory exam shows reduced chest expansion, but a normal respiratory rate. Bibasilar rales. So again, rales is kind of that out-of-date term for crackles. So we are talking about the kind of Rice Krispie sound, typically on inhalation, and this is in both of her bases. And reduced sounds in the apices. So reduced sounds can be from either shallow breaths, like insufficient volume of air moving, or from reduced density when you're hyperinflated and there's so much air that it's very difficult to hear through it. She had imaging done, and her chest x-ray showed bulky bilateral hilar lymphadenopathy, basically bilateral enlargement of her lymph nodes. And the CT scan shown on the right kind of confirms the finding of enlarged lymph nodes. Now, I provided these scans so you can see these images. This would not be a testable question. I wouldn't expect you to be able to identify enlarged lymph nodes on either a chest x-ray or a CT scan. But as I really encourage you, especially in your final clinicals, if you're in an inpatient setting and you're reading the radiologist report, look at the images yourself. You really will start to train your eyes and really enhance your own ability to assess these kinds of scans. So following this discovery, the medical team ordered a minimally invasive lung biopsy. So let's talk for a minute about what this lung biopsy is and what is it for. So basically, a lung biopsy would be ordered when they're looking for the cause of some kind of interstitial lung disease. So it's typically after they've done imaging studies, they've evaluated blood and sputum cultures, and they still don't have a diagnosis. Common things they biopsy for are lung masses or lung nodules. It's called a mass when it's greater than 3 centimeters. It's called a nodule when it's less than 3 centimeters. It's diagnosed lung infection and other disease, and it's commonly used when there's unexplained fluid in the lung. So on the right-hand side of your slide, you can see an image of a patient getting a bronchoscopy done. So a bronchoscopy is a procedure to look inside the trachea and large airways of the lung. The bronchoscope is this thin instrument. It typically has a light, a lens for viewing, and sometimes it has a cutting tool on the end to cut something out and create the biopsy that way through the bronchoscope. So through the mouth, through the trachea, and then into a major bronchi of the lung to access a portion of the lung, either for viewing or to remove something and test it later. When they're doing a biopsy for the purposes of diagnosis and they kind of want to look around a little bit, they will typically do it through a bronchoscope because you can kind of go in and out different airways and look around. The other option that you can do is a needle biopsy. So in a needle biopsy, the needle is guided by CT scan or fluoroscopy through the chest wall directly into the suspicious area, as you can see here. So you know where you're going and you take the needle right where you want to go and remove some kind of mass or tissue or fluid that's in that area through the needle. So if your patient has a lung biopsy ordered, it can be helpful to know by which mechanism they got the sample out. This patient's biopsy revealed non-necrotizing granulomas consistent with sarcoidosis. Now, this is a pathophys condition that we didn't talk about in your pathophysiology course, so we're just going to do a really brief little synopsis of what this disease is. It is an idiopathic, we don't really know why, granulomatous inflammatory disorder that affects many organs. So not just the lungs, but of the organs that are affected, lung is typically the most involved organ. Because of the high percentage of people with sarcoidosis who have lung involvement, there are theories that the cause of this disease is maybe a response to something that's inhaled. But that's just a hypothesis that has not been confirmed. So the pathophys is you have an inflammatory response in the affected organ. And the inflammatory response is going to call white blood cells to the scene. In sarcoidosis, this is typically macrophages and T lymphocytes. This also causes fluid accumulation. Whenever you have an acute inflammatory response, you get vasodilation and increased permeability, and fluid comes along with it. The white blood cells that are called to the scene help coordinate and organize the inflammatory response. So you see increased inflammatory mediators. And as you can see in your notes, these are typically tumor necrosis factor, TNF, and interleukins, ILs. Now, the part that makes this disease kind of specific is these white blood cells and inflammatory mediators don't leave. They end up getting wrapped up together, and they form these non-caseating granulomas. So a granuloma, as you can see in this kind of cartoon image of one, is just a cluster of immune cells. When these granulomas are formed in the lung, they typically form along the lymphatics, and that was found in our patient's imaging, right? She had these enlarged and inflamed lymph nodes in the lungs, and then when they went in, they discovered these granulomas. So sarcoidosis can resolve. So in some patients, typically about like 60% of patients who have these granulomas form in their lung, they resolve without any scarring. So a patient can have this disease, and the granulomas can resolve, and they can kind of go on with their normal life. But about 40% of patients will have pulmonary dysfunction associated with this disease. The pulmonary dysfunction is largely caused by the continual formation of granulomas that leads to chronic inflammation in the lung. Of those patients that have continued involvement, about 10% will go on to develop full-blown pulmonary fibrosis. So that means that when these granulomas are there, the body reacts to them with increased activation of fibroblasts, and collagen is formed around the granuloma and they scar. And once you have scarring, now we're going to start restricting the movement of the lung, which is this fibrotic phenotype. So again, sarcoidosis, about 60% of patients will have this disease and it will resolve. About 40% will have continued lung involvement. Of the group of individuals who die from sarcoidosis, they die because of pulmonary failure. So many people, there's a huge spectrum of what this patient population will look like, but those that get very sick is because of this effect in the lungs. The very bottom of your notes, it describes some clinical findings associated with sarcoidosis. They include constitutional symptoms, and that's that collection of symptoms that typically appear together that kind of clinically represent systemic involvement of a disease. So you see fatigue, malaise, weakness, anorexia and weight loss, maybe a low-grade fever. The pulmonary symptoms kind of fit with maybe what you'd expect given the pathophys: dyspnea, cough, chest discomfort, and crackles. And those crackles can be from the fluid of the inflammation. They can be from collapsed alveoli, from the fibrosis that's limiting the inspiratory volume. Erythema nodus, can't say that word. That gets me every time. All right, let's try it again. Erythema nodosum, there we go, flows out, is kind of seen on the pictures here. It's these subcutaneous nodules. They can be kind of red or purple. They're typically tender to the touch. And it's a classic finding with sarcoidosis. All right, let's jump back into our case. So our lady had a lung biopsy, and she was diagnosed with stage 3 sarcoidosis and treated with corticosteroids. Now, the corticosteroids are on the scene because of the inflammatory nature of the disease. Corticosteroids, anti-inflammatory, and then evidence has shown that when steroids are added, it actually helps to shrink the size of the granulomas and helps to aid in patients moving into remission. So let's review her chart with the thought process of I'm gathering information to make a decision if I feel safe coming in as a PT and treating this patient. So her arterial blood gases are all normal. Normal oxygen, her pH balance looks very normal. When you look at her CBC, blood cells are within the normal range. White blood cells are a little low, and this is a common finding with sarcoidosis. Not low enough that you wouldn't treat anyway, but that kind of is an expected abnormal finding. Platelets are normal. So a patient like this with a systemic disease that has multi-organ involvement, there's going to be a whole battery of tests to look at other organs' potential involvement in the disease. So for liver function, ALT is an enzyme found in the liver. So you would expect higher levels of circulating ALT with liver damage. Her levels were normal. Bilirubin must be cleared by the liver. So if your liver isn't functioning properly, it won't be as good at clearing bilirubin, and you would expect higher than normal levels of bilirubin in the blood. So these two tests are evidence of normal liver function. The pancreas is kind of investigated by looking at some key digestive enzymes that are produced by the pancreas, the amylase and the lipase. If the pancreas is damaged or experiencing inflammation, these levels would increase in the blood. So these are normal. It does not appear that her pancreas is involved. BUN and creatinine, both normal, indicating appropriate rates of glomerular filtration, and all serum electrolytes are normal. So while she has a multi-organ systemic disease, these results kind of let the clinician and the medical team know that these organs are not severely impaired or damaged at this point. So she has pulmonary function tests done. If sarcoidosis, lung involvement, falls under the category of a restrictive lung disease, what do you expect her pulmonary function test to be? Given that background, what do you expect to have happened to her forced vital capacity? Well, restrictive lung disease is hard to get air in, So I would expect this to be reduced when compared to the predicted values for her age, size, and sex. What about the amount of air that can come out during exhalation in the first second, FEV1? Well, if you have less in, you're going to have less out. So I would expect this also to go down. If we looked at the results of her pulmonary function test and they were reported as a ratio, the FEV1 to FVC, because both these values are low, I would expect this to be normal. That's a kind of surprising one that I think would be normal when someone has these severe lung impairments, but it's simply because it's reported as a ratio. What about her diffusion capacity? Well, with the fibrotic changes, I might expect this to be reduced if the fibrosis in the lung is impairing diffusion in any way. So our PT assessment. From what we've learned so far from the chart review, there's nothing in here that would indicate that I wouldn't go in and begin my assessment. Talking to nursing to coordinate what you found in the chart review, but everything so far points to it's appropriate to start our assessment. So we initially look at how the patient is looking. We start head to toe. Inspection, she's alert and oriented. She's got good color. She's thin. Good color tells me good oxygenation. Thin is not cachexic necessarily, so it's just kind of in the normal to thin range. She's resting comfortable with no visible signs of distress. When I observe her chest, there's symmetry of chest. I don't see a lot of accessory muscle activation. It does not appear that she's working very hard to breathe at rest. She is a little tachypnic. Her respiratory rate is 26, but her inspiratory to expiratory ratio is normal, which is expected for a restrictive lung disease. The inspiratory to expiratory ratio can get out of its normal range more commonly with an obstructive disorder. She rates her dyspnea a 1 on a 0 to 10 scale. Her extremities appear normal. There's no digital clubbing, so no evidence of chronic hypoxemia. No cyanosis, no evidence of current loss of oxygen in her tissues. When we auscultate her lungs, I hear those bibasilar crackles, and there's reduced breath sounds in the apices. The crackles in the base could suggest fluid. It could be collapsed alveoli. I would guess that the reduced breath sounds are related to volume because she has this restrictive lung disease. The other reason that breath sounds can be reduced is if you're hyperinflated, and that's definitely not the case here. When I palpate, she's in a normal tracheal position, but I do observe that reduced chest wall expansion, consistent with her pulmonary function tests and her diagnosis. Let's assess her activity. These are her resting values. Respiratory rate of 26, we mentioned that already, a little tachypnic. Blood pressure 124/86, heart rate 72, and she's satting at 95 at rest. When she goes supine to sit, no change in respiratory rate, a little bump up of her BP, an appropriate rise of heart rate, and SATs are holding. So we go ahead and have her stand up. Again, she's doing all this independently. So her respiratory rate does jump. We see a little orthostatic hypotension, maybe compensated with a slight higher bump in heart rate, but kind of right on track. And SATs are falling just a little bit. Let's give her a minute to catch her breath and maybe do some nice big deep breaths, possibly some ankle pumps or kind of lifting her legs a little bit to get the blood moving. And we see she kind of calms down. Breath comes down, BP stabilizes, pulse ox comes up a little bit. So let's try taking a walk with contact guard assist. As she walks, we see appropriate elevations in systolic blood pressure and heart rate. Diastolic pressure goes down a little bit. In phys activity, we went through the changes in vitals that might make you stop exercise. And while it's an unexpected finding that your diastolic pressure would drop, and you'd expect it to pretty much stay level, a reason to stop exercise isn't necessarily a drop in diastolic pressure. In fact, on the list of reasons that you stop, an excessive rise in BP, so like systolic pressure over 250 or diastolic pressure over 115 makes the list, but we don't see a drop in diastolic pressure alone as a reason to stop exercise. If systolic pressure dropped more than 10 millimeters of mercury with an increased workload, that would be a reason to cease activity. If there was a failure of her heart rate to increase with increasing activity, that would be a reason to stop exercise. So this is a little kind of concerning, unexpected, but it has not crossed the threshold for stopping all by itself. So she's able to walk 100 feet with a wheeled walker, but she fatigues very quickly with noticeable shortness of breath, and she begins coughing, and you stop the assessment. So she ultimately ambulated 100 feet. You document her vitals that you observed during that period of walking, and then described the subjective response that you observed. So, if you look at this as a whole, she did pretty well. She was mobilizing really independently out of bed. She was able to walk for 100 feet, and that's great, but desatting to 90% with 100 feet of walking is not going to be an easy, that's just is not a good functional place to be for appropriate abilities concerning your ADLs. So there's work to be done here in helping this patient. We can do training to help her become successful in completion of ADLs and tasks. We don't want her to lose these ADLs altogether because of shortness of breath and desatting. There's things that we can do to intervene here to help this patient be successful, even giving her underlying diagnosis. So this is a list of some PT interventions that could be appropriate for this patient. Looking at your assessment, looking at this patient's diagnosis, appropriate treatment goals for this patient would be to adapt the environment to make her ADLs a little easier, to effectively train her to alter the performance of her tasks with the goal of reducing energy costs. If she's going to have a chronic lung dysfunction going forward, you would like her tasks to be able to be successful with the least effort possible. And then incorporate methods to relieve symptoms associated with the activity. Give her tools in her toolbox to know what to do when she's starting to feel breathless, when she's starting to have the subjective signs that her physiology isn't tolerating what you're asking her to do. So these goals all fall under the larger heading of functional training. Let's go through some examples of what functional training is. The first is the energy conservation. So if you can identify problematic ADLs and modify the environment that the ADL is being performed in, she can be successful without any physical change. So for example, where she does work, like where she does the dishes, could there be supportive sitting in that spot where she does that activity? If there are frequently used items, can you put them all in a convenient location so it takes fewer steps to get to them? Or any given task requires less like motor involvement. Educating patients on using tables and counters to slide objects instead of carrying them from place to place, placing chairs around the home to allow for rest breaks, and then prescribing adaptive equipment can all fall under the general category of energy conservation. Educating our patients on ways to reduce dyspnea. The first is to really talk to patients about posture when it comes to respiratory muscle function. Patients with chronic pulmonary disease just end up in this totally forward-rounded posture. The use of accessory muscles pulls everything inward, shortens accessory muscles, causes adaptive shortening, shortens pecs. And by bringing the shoulders back and getting an upright posture, there's just more space for volume of air to come in. So you'll see this all the time when you're treating patients, that as they start to work and there's a greater demand on their pulmonary system, their posture just gets worse and worse as the muscles kind of move in and tighten. And it's very subconscious and patients don't realize they're doing it. So just educating them on that awareness, body awareness, that it's happening, teaching them, how to pull their shoulders down and back, that they should stop the activity, reevaluate their posture, take a couple nice big breaths in an upright posture, and then keep going, can make a huge difference than just, barreling down the dyspnea path and creating worse and worse and worse mechanics of breathing. At the same time, your body is needing more oxygen. It's just this vicious cycle that very quickly devolves into desaturation and dyspnea and shortness of breath and anxiety. And then anxiety is going to make all of that worse. So giving people the confidence that, yes, you have a chronic situation going on in your lungs, but you have control of the periphery and the skeletal muscle system that actually controls that pulmonary system. And here's what it feels like to stand up really nice and straight. Take a big deep breath. Can you feel the difference? And they absolutely can. You will have to reinforce posture about 1,000 times before it becomes more automatic, but take the time to give them, this is in a separate section, but take the time to give anterior chest stretches to help undo that adaptive shortening and allow for a better musculoskeletal alignment to support this functional training of posture awareness. Another one that can feel surprising maybe is to avoid bending at the waist. When you just straight bend in half at the waist, you kind of pin yourself right in the middle. Really limits the movement of the diaphragm during inspiration when you're bent in half. You're also more likely to use a Valsalva, which will increase blood pressure and can increase breathlessness feeling. So educating patients on the difficulty it puts on the pulmonary system when you just kind of bend your body in half, bending at the knees, keeping an upright posture when you're doing an activity that requires bending will create less breathlessness. Bringing the work closer to you. Don't be reaching out far away from you to do your work. And then using the Borg scale can be a great way to increase awareness of dyspnea. Typically, we just kind of ignore dyspnea in this mid-range. And then all of a sudden, once they get into trouble, it's like, bam, I'm in this scary place where I can't catch my air. But they had subjective signs along the way. And sometimes it's just helping patients identify it, name it, maybe keep a journal where they have done an activity and they see how dyspneic they get. It's mainly an awareness thing, to have them aware early on when they start to get a little breathless, to start, kind of going up into their tools and making some changes. You can utilize breathing techniques. We will do both of these in lab if we haven't done them already. Paced breathing, the main goal of paced breathing is to use breath and movement to control the breathing rate. As soon as we start to increase oxygen demand, we will start to increase respiratory rate. If someone is having a difficult time getting air in, they're more and more likely to take on a tachypnic breathing pattern. Paced breathing controls the rate. So if you're doing a rhythmic activity, you match your breathing to the rhythm of the activity. So you can do this with stairs, where they take a breath in on the up step and a breath out when they bring the next foot up to the step. If it's a non-rhythmic activity, you can instruct them on breathing in at the beginning of an activity and then breathing out to the forceful part of the activity. Basically, you inhale on the rest and exhale on the work. If you utilize paced breathing, it helps patients slow down, kind of set priorities, get organized, and have rest breaks along the way. And this all helps with completion of a task. So some other cues we give during paced breathing is like exhale during the hardest part of the activity. So an expression we often use is like blow as you go. Like when it's time to go is when you do the exhale. So if you're standing up from a chair, take a deep breath in before you stand and then exhale as you go. Push, as you stand up. So we'll get a chance to practice all these and you can feel how that can help control the rate. For pursed lip breathing, we talked about the physiology of pursed lip breathing in pathophysiology as it relates to airway collapse, which, if that does not sound familiar, we will review that concept in the obstructive lung dysfunction portion of this class. But pursed lip breathing is in the category of relief of dyspnea, because pursed lip breathing also helps to slow your respiratory rate down, simply because it takes longer to exhale through your pursed lips. So using pursed lip breathing can help patients avoid slipping back into their natural patterns of shallow and fast. So you instruct your patient, breathe in through your nose and then out through a narrowed mouth opening for 4 to 6 seconds. It can be super helpful. It's very, very easy to do, and it can really help prevent those tachypnic patterns from coming through. So if you have been an asthmatic, or if you have seen asthmatics being told to pursed lip breathe, the primary reason for that is the control of rate, not so much the airway collapse. If you turn your notes to the next page, there's a little space for this conversation of why does a larger tidal volume decrease dyspnea? Like, why do we care if they use frequency over volume? Minute ventilation is just frequency times tidal volume. So why is tidal volume inherently better? Why couldn't you just go super fast on your frequency? Both should equally increase minute volume or minute ventilation. The reason is because we're not just worried about filling up the volume of the lungs, because the volume of the lungs or the area of the lungs are not all created equal. Not every part of our lung participates in gas exchange, which is the whole point of breathing in oxygen, right? We are trying to bring oxygen in order to allow diffusion of that oxygen to move into our blood. If I draw a very simplistic lung where we have our trachea bifurcating into bronchi and then ending in a single alveoli instead of a, webbed tree of a million bronchioles, the first half of this picture, this whole area, is called the conducting zone, or the area where gas moves through but does not participate in gas exchange. When you get down to the very bottom, this is the respiratory zone. This is the area that actually participates in gas exchange. So the volume of our conducting zone, also called your dead space, right, the area that does not participate in gas exchange, is anatomical. It's just the volume of the tubes that lead to the respiratory zone. And in typical anatomy, let's just do the generic 70 kilogram male, the conducting zone is around 150 milliliters. So the purpose of this description, we're going to just say the conducting zone is 150 milliliters. That is the volume of dead space air that anatomically exists because not all of our lungs participate in gas exchange. So this lung took in a big breath and the respiratory zone allowed gas exchange to occur. So at the end, when you're about ready to exhale, right, this alveoli is full of carbon dioxide. Let's redraw this picture as an exhalation. So here's our same very cartoonish single alveoli lung. Get down here. And we've got about 150 mils of dead space air. And what is that filled with as we exhale? Well, it's filled with the remaining air that had been in the lung. So basically, your dead zone is filled with the carbon dioxide that was just collected in the previous breath's respiratory zone, right? You've just moved that carbon dioxide. Now, sure, a lot of it has left the lung, but the last little bit of gas doesn't leave the lung. We don't wring the lung out dry. There's still air in our lung. So at the end of your exhalation, your dead space is now filled with, we could call it old air, or air that has already participated in gas exchange and is pretty rich in CO2. So now we inhale, right? So we just finished our exhalation. We're feeling great. Let's breathe back in. Here is our single alveoli lung. Please don't confuse this with actual anatomy. We have 150 mils of dead space air. What is the first air that's going to make it into our respiratory zone? It's the air that was just in the dead space. And now here comes the fresh oxygen down the pike. So if your normal tidal volume, resting tidal volume, not during exercise, is around 500 milliliters, and 150 milliliters of that tidal volume is dead space air, you're basically moving, right, about like 30%. 30% of your volume is just dead space air that you're moving. What if you decreased your tidal volume? Oh, that's kind of messy. What if you decrease your tidal volume and you're a shallow breather, which is the classic tachypnic, decrease in the volume but increase in the frequency? What if instead of 500 milliliters, you were only breathing in 300 milliliters, a shallow breath at a higher frequency? Perhaps the same minute ventilation between the two, just a smaller tidal volume. Well, now suddenly 50% of that breath is just dead space air. And remember, every breath in that we take requires energy. It requires muscular activation to move that air in and out. So a tachypnic breathing pattern is using more energy to move dead space air in and out, because a greater percentage of your total volume that you're moving is just moving dead space air. Where if you could take a deeper breath and you could actually increase your volume, you would get more fresh air in each individual breath, a smaller percentage of dead space air because the total volume would be bigger. Which is exactly why what the normal acute response to exercise is to first increase our volume. When you start to exercise, the first thing you do is start to breathe deeper, because it is much more efficient if you use the energy to move a greater percentage of fresh air into your lungs. And then the dead space goes along for the ride. So this is the reason why as soon as breath gets shallow, it becomes such an inefficient breath pattern, because they're using all kinds of muscular effort to move basically carbon dioxide up and down within the lung. A greater percentage of the total breath is dead space air. So if we go back into our printed notes, under functional training is breathing retraining. So really talking patients through so they stop doing breath holding. We said in the very beginning, the first lecture of the semester, the people hold their breath to create stability. So if they don't have a good core activation, they can breath hold and create a rigid tube, and the increased central stability increases peripheral force generation. So it works, right? It definitely works to increase their peripheral force generation, but it's going to make them really breathless. And if your underlying issue, the reason you're having trouble with ADLs is because you have a lung dysfunction, then using a breath holding strategy is incredibly detrimental to performance, ADL success, all those things. So working on using eccentric breath control where they're, using voicing, or some people like to hum, something that allows some central stability with the diaphragm, but mobility and allowing more fresh air in and avoiding those breath holds and Valsalva. Talking to patients about not doing unnecessary talking during an activity, which can be very tricky. I only laugh because I love trying to tell old people not to talk as much. They really take that well. But it is important. It takes so much more energy to talk while you're doing an activity. They need to focus and stop telling you about the Packers. Okay. So using pursed-lipped breathing and paced breathing is a really, really great breath retraining strategies that we've already talked about. Utilizing relaxation techniques to calm the anxiety associated with dyspnea and breathlessness, and having that tool in their toolbox to calm themselves down when they start to kind of have the subjective feedback that the body is starting to go into a dyspneic pattern. So in our interventions, we talked about functional training and breathing exercises, and then we just use good old-fashioned exercise, right? All the stuff that we already talked about in phase of activity. Prescribing endurance training. Typical frequencies, 3 to 5 times a week, 20 to 60 minutes at a time. Obviously, you might need to work up to that. If you have a very debilitated patient, you want to start with really short time frames because that builds in the frequent rest breaks. And then your goal can be to reduce the rest breaks. So you might not, for a while, increase total exercise time, but if they can exercise for greater chunks of time before they need the rest, that is progress. So this kind of patient could go into a pulmonary rehab setting. They can do unsupervised sessions at home with specific guidelines. That's super effective. By the time this patient is discharged, she has the capacity to be able to do this kind of exercise on her own. We just got to make sure that when we have her, we get the message through. The benefit of the endurance activity, all the phys of activity stuff, of how endurance training can make your periphery better at using oxygen, can have such an important impact on this patient. So the mode really doesn't matter. It's whatever mode they're most likely to do. For basically almost all of our patients in the cardiorespiratory world, we really need to take the time for the warm up and the cool down, because the faster the change, right? Our bodies just don't adapt well to acute changes. If we allow the time to ramp up, patients will be more successful in the activity. They'll be less likely to fall into dyspneic and tachypnic breathing patterns if they give the body the chance to warm up and then go with themselves on the cool down. For the intensity, it works really well in this group to do, it's supposed to be RPE, rating of perceived exertion. Dyspnea scale can be incredibly effective using one of your MET charts to give them ideas of different MET levels. The rules still apply, right? The higher the intensity, the more physiological improvement you will get from aerobic fitness. So this one, you have to judge what the patient is capable of and what is possible. But the goal is to prescribe exercise that does have higher levels of intensity, whether that's moderate intensity might be more appropriate, or if they can accomplish higher intensities, they will get more out of the training. I really encourage you not to under-prescribe exercise out of some kind of a conservative do-gooder, like you're trying to protect them, but we want them to have the physiological impact of the exercise. I can't resist. I have to know this stuff made it into your head from phys of activity. What are we thinking of when we say, yes, it is worth going to a higher intensity because I want a physiological benefit? What can we give them? We can increase their VO2 max, the maximum amount of oxygen they can take up, because we can increase peripheral oxidative capacity. We make the periphery better at using oxygen. We can increase the capillaries, so capillarization of muscle. I forgot to put the increase. We can actually have more blood vessels. What does more blood vessels give us? Well, decreased diffusion rate, decreased diffusion distance, which improves diffusion rate. With training, you can decrease heart rate for a given work rate. Well, if your heart doesn't have to beat as fast, that's less oxygen demand of your heart because your heart is working when your heart is beating. You can delay the anaerobic threshold, the lactate threshold, some people call this. So that's really huge. If we're thinking about exercise intensity, how hard is our patient working, and their minute ventilation, we see this linear relationship, and then something happens where all of a sudden it bends up, and we have a greater increase in ventilation than would be expected based only on exercise intensity. So if nothing else changed, you'd expect minute ventilation to keep going up linearly. But there's this bend because when we get to a certain exercise intensity, we start relying on anaerobic metabolism. When we're running glycolysis really hard, we start making a bunch of lactic acid, which has to be buffered. How do we buffer that? We increase our respiratory rate to blow off the CO2, which is the acid, pulling the hydrogen out of the blood and maintaining our pH. Well, if you have a patient with a pulmonary dysfunction and they have a restrictive lung dysfunction and they can't get as much volume in, the sooner this happens, the worse it is for them, because now their lung is doing two jobs. It's bringing in the oxygen to fuel the activity, and it is buffering the lactic acid. We want this to happen as late as possible. We want our patients to be as good as they can possibly be with aerobic energy production, because we can't fix what's going on in their lungs, but we can make their periphery better at using oxygen. Strength training is appropriate and great for patients with pulmonary dysfunction. You often have to start with a lower resistance and kind of increase reps first before you can start doing higher weight. But strength training, there's a lot of research that has looked at upper body work. It's really important for the pulmonary system. So much, all these accessory muscles of respiration are attaching onto your upper body. And upper body resistive work can improve dyspnea, fatigue, and respiratory muscle function because of this synchronous relationship with the thoracic cage. So strengthening these muscles is really important. We will talk about this in lab. In general, when patients are doing upper extremity work, like in their ADL life or anything that requires their arms, they're much more likely to get dyspneic. And you'll hear your patients talk about this all the time. That's the thing that really trips them up. The reason for that can be complicated, but a lot of times people start holding their breath when they do upper extremity work. They can develop these asynchronous breathing patterns. So if you incorporate upper body strengthening and really reinforce breathing techniques and appropriate breathing strategies during that, there'll be carryover into that upper body work. So you get the benefit of the strength training, which by itself is good, but you can also do retraining of upper body work if you're really taking the time during the strength training to reinforce your breathing strategies. There's a big carryover into ADLs that can make a big difference in their dyspnea, reported dyspnea. Flexibility exercises are so important basically for the anterior chest. They get so forward rounded. So the goals here are to improve posture, range of motion, decrease stiffness, and obviously prevent injuries always on there. We will talk in lab about how you can get more bang for your buck if you just do flexibility with your breathing exercises and vice versa. In every field in PT probably, but especially in cardiopulm where you have sicker patients who have lower endurance, getting more benefit out of one individual exercise can go a long, long way because they might not have the stamina to do a ton of stuff. So we will talk about how, if you're going to do forward, an anterior chest wall stretch, take a huge deep breath and allow the breath to help, supercharge the stretch with the stretching from within with the breath. And then they're getting the breath work and they're getting the flexibility, and it's all in one. And it can be a really nice place to work on both at one time. And then I always have to end with this because we have all kinds of cool stretches and they work really well. But if you really want to stretch someone's chest out, what's the best way to stretch their chest, independent of motivation, independent of effort, is just get them moving. As soon as you're doing exercise, your first thing you're going to do is increase tidal volume. You're going to take deeper breaths, and that will stretch the chest wall. This is, again, more bang for your buck. Get them doing something aerobic and take nice, deep breaths during that aerobic activity. They could, you can do interval training during to get some high intensity work, and then when you get low intensity during kind of the rest, doing some anterior chest stretches, just some shoulder squeezes, get them back, and then boom, back into your high intensity, and you can kind of cross breed these to maximize. But as soon as somebody starts exercising, physiologically, they're going to start taking deeper breaths. And we can exploit this. And now we're starting to kind of add layers on our, what do you get out of your exercise cake? And there's so much here. Plus, they're going to feel good. Exercise always makes you feel good. Once you get past, the part where you hate it. All right, that's it, folks. I hope you have a wonderful day. I look forward to seeing you in lab. Bye.